Hello and welcome to We Debate. I'm Joe Munene. Now, in 2018, the government launched a pilot scheme for universal health coverage. 4 years later, and with many lessons learned and a new government in place, there's a renewed sense of purpose on delivering on UHC. But one thing is clear, it will cost a lot of money to roll out. And as it is, the health sector is already relatively underfunded. So what should the government's priorities be? Where should the government direct its efforts and investment in the drive towards achievement of universal health coverage? This is good for debate.
The debate motion for tonight. Let it be resolved. The government's investment in universal health coverage should focus on primary health care, not secondary and tertiary care. Debaters for tonight are, on the affirmative side of the debate we have Dr. Jose Arono, co-founder and managing partner, ENK consulting firm and UHC champion. On the negative side of the motion we have Dr. Victor Ngani, group medical director at RFH.
Dr. Arono, Dr. Victor Ngani, welcome to this debate session. The motion for debate, let it be resolved. The government's investment in universal health coverage should focus on primary health care and not secondary and tertiary care. Dr. Arono, you are arguing on the affirmative side of this debate. Dr. Ngani, you stand in opposition. As explained, we will start off with 1 minute opening remarks. Thereafter, you'll have the opportunity to make your main presentation, which should be 5 minutes. Now, as part of this debate, we have a panel of jurors, 3 members of a jury panel who will be listening and evaluating on your respective arguments on this motion.
On the jury panel we have Juror 1, Marie Claire, convener, Kenya Medical Association Young Doctors Network. Juror 2, Dr. Ibrahim Alkama, Senior Medical Officer, Nairobi South Health Center, Nairobi City County. Juror 3, Dr. Crystal Serena Vulavu, Kenya Medical Association, Nairobi Division.
Prior to the start of the debate, we have polled the jurors to get a sense of where they stand on this motion. And all the 3 jurors are in support of the motion. So I think, Dr. Arono, you are starting with a massive head start. Dr. Ngani, you have a lot of work to convince the jury panel to move to your side of the debate. The idea is that at the end of the debate session, we will poll the jurors again to get a sense of where you've managed to shift them with your arguments. So to start off, Dr. Arono, we give you 1 minute opening statement. Over to you.
It's a pleasure to be here to discuss a very pertinent topic, universal health coverage. What does that mean? It means that individuals like yourselves, communities, and all of us have access to health care that is of appropriate quality and covers the need of this individual and does not expose the individual, the community, to financial hardship. Why is universal health coverage important? It's important because health is a right, just like any other of the human rights that we celebrate in this country. Now, the question today is, how do we get to UHC in the current context of the Kenyan government? Do we go through it to primary health care, or do we go via secondary or tertiary health care? I'll be here to argue in favor of primary health care. And what is primary health care? Primary health care is a whole of society approach to health that really ensures that individuals have access to essential health services that caters for the majority of the needs of the society. And has been shown repeatedly that is one of the most cost-effective and equitable way to use available resources to provide health care to people. I look forward to this debate.
All right. Thank you, Tertiary. Dr. Ngani, your 1 minute opening statement.
Indeed, most important conversation today, and I'm glad we're discussing UHC. This debate is focusing on a specific issue. Should we focus on quantity or should we focus on quality? Dr. Arono has described UHC as it's supposed to be, and the intention is to protect every citizen, every member of the community from financial hardships when they access healthcare. Indeed, I'll present in the course of this debate why I believe that it is more prudent to achieve the goals of UHC if and when we focus not just on primary healthcare, but also fundamentally on secondary and tertiary healthcare. what is secondary and tertiary healthcare? The simplified version of primary, secondary, and tertiary is this. The first person you meet, the first point of contact when you go to a hospital is the primary healthcare person. When you have a common cold, when you have a cough, when you have a flu, that is the person you see. But when you are really sick and you need care and you have to go to a hospital for admission, for surgery, for cancer treatment, then you're moving into the space of secondary and tertiary healthcare. And my view is that this is the one area where families face the greatest hardships, and this is when the government must step in.
Thank you, Dr. Ngani. Now we circle back to you, Dr. Rono. You now have 5 minutes to make your main body of presentation. Over to you.
Thank you. So we don't exist in a vacuum. Kenya is part of a global community, and each of us is part of this nation. So let's start with a few fundamentals. Where are we as a country? So universal health coverage is indeed a process and not a destination, and needs significant investments. And there are a couple of metrics that define how well we are doing in terms of those investments. And today we're talking about government-led investments. So first off, how much are we spending as a country on health as we speak now? For you to go towards universal health coverage, you need to spend about $86, about close to 9,000 or 9,500 shillings per person in terms of government health expenditure per capita. In Kenya, we are hardly at 30%, meaning there's a huge gap in terms of the fiscal space. Secondly, African countries, including Kenya, have committed to invest 15% of GDP towards health. Kenya has not gotten to that level yet. Thanks to devolution, we're probably approaching it. We're probably at 11% now, but far off from that 15%. And lastly, countries that have gone towards UHC spend at least 5% of their GDP on health. Kenya, we are about 2.2 or 2.3%. What am I trying to tell you? I'm telling you that from a government perspective, there's still a huge deficit in terms of investments. What that means is threefold. That on one hand, UHC needs 3 parameters. It's a question of how many people are you covering, what is the scope of services you're giving them, and how much financial hardship risk do they stand. So as it is now, the people who are covered in Kenya reliably from a health insurance perspective, probably about 20 or 21%. And in terms of the availability of services, from a recent survey by the government, you're about 42 or 43% of essential services being available to Kenyans. And lastly, out-of-pocket expenditure that Kenyans are paying is significantly high, meaning that in Kenya, we're about 26% of total health expenditure coming directly from people's pockets, meaning people are at risk of hardship. That means the fiscal space for health is significantly constrained. What does that mean? It means we need to be very prudent with the available resources. So what resources give us the best return? We've done a significant amount of work, including in my own career, to look at what is the return on investment for community health or primary healthcare interventions. One of the most rewarding investments is immunization. For every 1 shilling you put in, you get 16 shillings out. The second one is community health. You put in 1 shilling, you get about 9 shillings back. You'd hardly get to those numbers with secondary or tertiary care. You just don't get those returns. And when resources are limited and they're tax-based from citizens, then you need to find the most rewarding investments to put money in. And community-centered primary health care has been shown repeatedly to be that investment. And I preempt that my colleague would try to convince you that what really pushes people to economic hardship is health conditions that are so severe that impoverish households. But I'm here to tell you that primary health care is a step ahead and is asking the question, why don't we prevent those events from getting to the critical level where you need tertiary health care? Why am I saying this? If you look at Kenya today and ask yourself, what kills people? There are top 10 diseases that kill people are diseases like HIV, malaria, diarrheal diseases, pneumonia in children. All these diseases, 80–90% of them can be prevented and sufficiently treated at primary healthcare level. So the risk that you'll get someone advancing to the point of where they need tertiary healthcare is significantly low if we actually invest in primary healthcare. And ultimately, the question you ask yourself is, what's government's mandate? The debate today is about government. What's your job as government? Your job as government is to protect the people you serve using the taxpayers that you've collected from them. What does that mean? It means you've got to take that tax money and ask yourself, you're pulling this money into one basket and you're going to use it for everybody. You've got to start with what is most equitable, most rewarding as an investment, and what gives the majority of the people access to healthcare. And I'm here today to argue that primary healthcare is the way to go. Thank you.
All right. Thank you, Dr. Rono, for your presentation. We now take your 5-minute presentation. Dr. Ngani, over to you.
Well, I feel compelled first to make just 2 clarifications. Number one, our expenditure on healthcare today stands at 4.6% of GDP. I agree it is less than what we should have, but it is not 2-point-something%. The second issue is Dr. Rono has mentioned the leading cause of mortality in the country, malaria. In fact, the 3rd leading cause of mortality is cancer, and this is after infectious disease and cardiovascular diseases, meaning that cancer and cardiovascular diseases are number 2 and number 3 in terms of causing mortality in Kenya today. We are talking about 27,000 people dying of cancer every single year, something that in the Western world, they're having significant reductions in mortality. Now, why am I talking about treatments like cancer? Because in the context of primary versus tertiary versus secondary, the matter of cancer treatment lies in tertiary care. The matter of neurosurgery lies in tertiary care. Any kind of surgery that you require lies in secondary tertiary care. When you talk about dialysis, it's tertiary care, ICU, tertiary care, the basics of life that people need today. These are not in primary care per se, they're in secondary and tertiary care. Yes, primary care is important, but primary care is not what is driving families into poverty. The biggest part of my presentation today is that we have to go back to the basics, the fundamentals. The fundamentals are this. We are addressing UHC. And what is UHC purposing to achieve? Number one, that all individuals in the community access the healthcare that they need. All. They access the healthcare that they need. Should we say that we are giving UHC if when you need dialysis you cannot get it? Can we say that you are achieving UHC if you need cardiac surgery you cannot get it? Can we say that if you need a specialist you cannot see that specialist and we call that UHC? The first answer to that question is no, that is not UHC. That is some level of care that focuses on volume as opposed to quality. I said that in my introductory remarks. Today in our country, we have patients who are being treated over and over again for malaria and typhoid for months, and they have cancer. Why is that? Because the processes of diagnosis, the processes of access to a healthcare person who is able to make those decisions, it's not there. It's limited. In fact, I want to tell you, as much as you're arguing about UHC, in this country today, we have some form of UHC. Our public facilities are actually financially accessible. Many of our health centers, you pay 50 shillings, 100 shillings. Most families can afford that. I agree, there are many families that do not afford it, but in fact, most families can afford that. What they cannot afford is a situation where you need to invest massively in healthcare. All of us have been part of fundraisers, trying to meet a hospital bill, trying to get a loved one into a space where they can get healthcare. Many families today have to make a decision between good health care or just taking the health care they can afford. This is our reality, and we have to change that. And therefore, my view is that for us to impact society, to achieve the real vision of UHC, then the government has to make these services available. Unfortunately, only 8.7% of Kenyans are able to access voluntary insurance schemes, and a further 9.9% are getting insurance through the social scheme. These numbers are paltry, and it's because a big majority cannot afford either the social scheme or cannot afford the voluntary scheme. What can we do as government? Make healthcare responsive and accessible. We've spoken about us not being in isolation in the global village. The current situation is one of the best examples of UHC is the British system, the national health system. And in that system, 2 things happen. Number one, they actually cover every citizen of the country. And number 2, they get access to all levels of care. If you need surgery under NHS, you're going to get it. If you need cardiac review, you're going to get that. A specialist, you'll get it. Why should we say there's a standard of healthcare for Africa, which is poor? You can't have a cardiologist, you can't have dialysis, you can't have surgery. Yet in Britain, you can have surgery. Why do we say UHC for Africa is different from UHC for Canada, UHC for Japan, UHC for Britain, where all these things are possible? And then finally, ladies and gentlemen, let us not confuse UHC versus the mode of payment. What my colleague is talking about is what is called a sort of a social healthcare scheme where the government is paying. It doesn't have to be that way. We are not talking about a single payer system. We are talking about a system where it is funded, yes, but everybody has access without facing financial hardship. I put it to you today that it is not paying for the headache in the center that's going to make you face financial hardship. It is having to pay 100,000 shillings a day in ICU that's inaccessible. Thank you very much.
All right. Dr. Rono, are you in agreement on some of those points? Your opportunity to rebut.
I wish to state a few clarification to my worthy colleague that I think the viewers need to get right. So first, I think the premise of this debate is about government investment. And I think we need to come back to that repeatedly in this debate and ask ourselves, what do we mean by government investment? Government investment is primarily taxes that you've collected from Kenyans and not necessarily my own money that I'm voluntarily paying for as a level of care that I wish to choose. This is about government financing, and I think we need to get that correctly. So if we're talking about government investments, the question is where best do you put that money? And my colleague mentioned that, you know, government health expenditure as a percent of total health expenditure is about 4.6. But I would invite him to check the latest numbers, and that number is hardly anywhere beyond 3%. The latest numbers from the government itself put about 2.2 or 2.3. So we are yet to cover another 2.7%. So before, we don't have the luxury of misusing the available resources. We have to use what we have prudently. And secondly, my colleague mentioned about what really kills people, about cancer, about hypertension, and people are being treated a lot for malaria and typhoid, yet they have cancer. And that really speaks to my point, because this person who is being treated for typhoid and malaria instead of cancer is because he has gone to a primary health care facility that is not functioning well, that can't differentiate between the malaria and something else. If we invest adequately in primary health care, we'll get a rapid diagnostic test for malaria. The clinician would know, okay, this is not a case for malaria. Let's find something else or refer the patient upwards to get appropriate care. So again, the point he makes really emphasizes the fact that it's a primary health care that is lacking at this point. The other point I wish to make is that if we look at countries that have gone ahead of us in UHC, I mean, there's very good examples, and I'll talk about the example of Thailand that has been shown to be not necessarily a high-income country, but has gone on to achieve universal health coverage. What have they done? They focus primarily on primary health care, starting with children under 5, expectant mothers, then focusing on the elderly, and then closing the middle gap of people who are in their 30s or 40s who are generally healthy. And how do you do that? You cover the things that really affect most of the people. And again, I would want to emphasize that my colleague mentioned that, you know, cancer is the number 3 killer in Kenya, and that's not true. If you look at the entire population, the top killer is HIV. The second one is lower respiratory tract infection. The third is diarrheal diseases. The fourth is protein energy malnutrition. Again, back to the basics, nutrition. The fifth is birth asphyxia and trauma. The sixth is stroke. And he talked about headache, and you know, you don't treat the headache and yet someone has probably a cardiovascular disease. The fact that the patient has come to a primary health care repeatedly complaining of headaches and you don't pick the potential case of hypertension talks to a deficit at the primary health care level, meaning we're not investing enough at primary health care level. And so my point is, if that is a challenge, do we then strengthen the tertiary health care, or do we come down to primary health care and say, this is where the problem is. We didn't get this patient who didn't have malaria. We kept treating them 5-6 times for malaria. Let's invest at that primary healthcare level. Let's get basic point of care diagnostics. Let's train the healthcare workers to be able to differentiate between malaria and typhoid and a potential case of hypertension or stroke. That is where the investments need to go. And lastly, my colleague talked about families being in hardships and people having fundraisers, and that's a common occurrence in Kenya. But again, we should ask ourselves, are we treating the symptom or are we treating the root cause? By the time families are gathering for a harambe, for a person who suffered a stroke, 2-3 years back, that person just had hypertension. It just started. No one picked it at primary healthcare level. It progressed. He now got into a stroke. He's paralyzed, he's lost his job, and families have to gather. And I think here, when we come back to the focus of the debate and say the debate is about government investments, the question is, where should government put that money? And my argument is that government should go back to that primary healthcare level, make sure that hypertension was picked up. If that hypertension was picked up, then this Harambee wouldn't arise. I rest my case. Thanks.
All right. Thank you, Dr. Rono there. Dr. Ngani, your rebuttal?
The reality, and you can look at the National Cancer Task Force report, July 2022, just this year, and actually global statistics around Kenya. Number one, our leading cause of mortality are infectious diseases, all of them lumped together, not broken down. Number two, cardiovascular diseases, and number three is cancers. And indeed, as we progress in this fight against infectious disease, we will see greater prominence of this, what we call non-communicable diseases, a big burden in Kenya today, and I do wish that we don't understate the significance of those diseases in society today. There are many, many families that are suffering from this, the adverse consequences of this. Number two, this question is a fundamental question. We are speaking about picking disease early through primary healthcare. And indeed, it is true that a primary healthcare system that works will reduce the disease burden. But that's not the point of this conversation. The point of this conversation is how do we achieve universal health coverage and understanding the meaning. We make the mistake many times of being overly academic about the issues, and we pick conversations from other centers and other settings that are not Kenyan. You know, the examples of UHC, they're there. There are many of them in many parts of this world. Unfortunately, none of those situations mimic exactly where we are in this country today. And I'm going to reemphasize a point that I raised earlier. As it is today, there's a level of UHC that exists in this country. In fact, the previous government piloted UHC in several counties where you had access to many facilities if you just had, just belonging to those counties directly. In fact, NHIF today, anybody who's a member of NHIF and their families, they have access through the capitation scheme. They can go to any comprehensive NHIF hospital today and just receive care without paying anything else. This is the reality. But is that responsive? Is it addressing the issues? Dr. Rono, you can tell me, and I'll rest my case, if we say that it is fine for us to not take care of dialysis patients, I will rest my case. If you tell me that the patients who need surgery today, they should not get that surgery in our UHC, I'll rest my case. If you tell me that cancer patients today should not receive that care, I'll rest my case. But the converse is true. Some of the biggest milestones you've achieved through NHIF, and I must say, our biggest route, our most practical route towards UHC is NHIF. The biggest improvements to healthcare delivery in this country, to financial protection, to reducing hardships that families face as a result of healthcare expenditure, has been when NHIF took steps that protected the community against these hardships. What am I talking about? At some point around 2013, NHIF introduced dialysis, paying for dialysis. Suddenly, mothers and families that couldn't access dialysis got access to dialysis. When I was doing my internship in Kenyatta, if you had kidney disease, the first question it would ask you, can you afford to pay 60,000 every month for the rest of your life? Many people sold everything they had for dialysis, had dialysis for 6 months, leaving everybody else in poverty. But when NHIF came in, suddenly that burden was lifted and many patients have benefited. In addition to that, Moi Teaching and Referral Hospital today does more kidney transplants than any other facility in this country. That has brought tremendous relief. The second milestone, when NHIF introduced coverage for surgeries, suddenly a teacher working in a remote area could get surgery in a private facility, get a knee replacement. Even today, our own facility, we are doing more than 35 knee replacement surgeries for people who didn't know it's possible to walk again because of a system that focuses on their needs. We are talking about NHIF introducing coverage for cancer therapy, 25,000 per session of chemotherapy. You look around and see how many families have benefited from that scheme. These are the practical steps in Kenya that have made a difference. And you are saying, let's roll this back. I can't accept that. And I wouldn't recommend you do that as well. It's important to understand what is ailing Kenyans, what is causing burdens. Even today, with the 25,000 plus paying for CT scan, families still have to chip in something to cover cancer. Ladies and gentlemen, I ask us to move away from the books and look at the practical life situation that many of us are going through. And if we do that, we'll definitely agree that the point we need to intervene on is tertiary and secondary care, where the burden is heaviest. It is true, eventually when primary health care is done right and tertiary health care is done right, we'll reduce the need for tertiary health care. But where are we today? Should we wait for this generation to die as we focus on primary health care and leave the poor to their own devices? Look at an example of Canada. Those who have money are able to access greater care. Those who don't have money are fixed with the government system. The government systems in Canada are very, very good. Would you say the same for the government systems in Kenya. Ladies and gentlemen, I'm asking us to rethink and look at what is important and make decisions and investments that actually impact lives in Kenya today.
Thank you very much. Maybe a quick question before we take the break. The pilot scheme that was undertaken in 2018, and I believe it's still ongoing, has it focused largely on primary to the exclusion of secondary care?
No, indeed, the pilot scheme actually covered all cases. In fact, you could walk into a public facility and receive surgery. You could walk into a public facility and receive primary health care. And that is essentially what it should be. The only challenge is implementation was not done the right way. And so you had an announcement, but you weren't prepared. So you'd find that the healthcare workers in those facilities were stretched. Provisions were limited, supplies were non-existent, and as a result, a program that was good in intention failed at implementation. Now, we need not throw the baby out with the bathwater. We can actually look at what didn't work in that situation and come back. Have a UHC system that looks at primary healthcare, secondary healthcare, tertiary healthcare, and in fact, Kenya should take its position in quaternary healthcare, which is when we begin to innovate and provide new solutions that can spread across this world.
I think the point about the pilots really demonstrate the point about primary healthcare. To be honest, the 4 pilots that were rolled out for UHC were essentially, events, ribbon-cutting events. There was no significant investment at primary healthcare level. If you look at, the launches that were done in different countries, does it really cover primary healthcare or even tertiary healthcare for that matter? People are given cards, but when you take that card, you go to your dispensary. You don't find medicine. You go to the dispensary, you don't find basic diagnostic kits. Then that UHC in itself, misses the point. And the example I was giving earlier of Thailand is not academic. Thailand was in very much similar situation with Kenya, and they started really focusing on universal health coverage from a primary healthcare level. And if I can take you back, if you talk about government investments, prior to the UHC, there was a major, public-private partnership that was called the Managed Equipment Scheme. Up to date, the Senate has been asking the ministries of health to justify that investment. There has been no convincing justification for that tertiary investment. But if you look at community healthcare and primary healthcare, and you ask them, and you ask Kenyans, where is the investment? And not to be academic, just looking at the hard numbers, in the shillings, for every shilling you put into community health, you get 9 shillings back. The question is, for every shilling you put in the MES, how many shillings do you get back? It's shrouded in controversy because there isn't really a justification. And I agree with my colleague that we are not saying the person with cancer or stroke should not be treated. The question here is, this is government investment. And I argue first that NHIF is not government investment. NHIF is a voluntary membership, either through your employer or yourself. It's not tax funds that go into NHIF. So let's distinguish between government investments and NHIF. NHIF is for the privileged few who are civil servants that have contributions to NHIF, to private organizations that have made contributions to NHIF, but it's not really tax funds. It's not like government collected taxes, put it in NHIF and said give care to people. So NHIF is not government investment.
All right.
And lastly, if I make one last point, if we look at a more practical example, and not to make it academic, let's look at COVID-19. Kenya and many African countries fared way better than more developed countries that have invested and have a lot of tertiary and secondary care. What really helped us? It's simple things. It's the hand washing. It's the immunization. We didn't have oxygen. People didn't survive out of COVID because we had good tertiary care. It's just because we wore masks, we hand washed, we had good nutrition. If it was indeed tertiary healthcare, we would have a lot more mortality than we did. So that really brings it home in terms of practical terms. Thanks.
Sorry, I must respond to this if you allow me, because I was very much smack in the middle of the COVID-19 debate. My background is in critical care, and I've seen some of the biggest challenges that you could ever face as a doctor at some point without your own value. And I think to misunderstand the details of this particular situation, why we fared better, I think we oversimplify it. It's not because of primary care, it's because of God's grace in many ways. Number one, as Africa, we've been exposed to so many illnesses, many types of coronaviruses that are not necessarily COVID-19, and our immunity is primed in this way. Number two, one of the challenges we've had is that our mean age in Africa as a continent is generally less than 20 years in many, many countries. And as you remember, COVID-19 would affect the advanced ages and so on. And I must tell you that when Africans got severe and critical COVID, the difference was limited compared to other countries, and this is a serious issue. So that's a bit of an oversimplification. Number two, the difference between focusing on what we call the theoretical versus the practical is when we look at the numbers and fail to understand the realities that are on the ground. Look, we are talking about NHIF being sort of a voluntary scheme. It's not the case. The reality is we are discussing situations where we want to reduce the impact of the financial burden on communities. NHIF right now is actually able to take care of the primary health care concern. The challenge that people are facing remains the secondary and the tertiary, and that's where we need to invest. We talk about managed equipment services for health. The MES, and I think we'll talk about it after the break, is a system that was rolled out very much in the same way as the UHC pilot program was run, where it was done without focus on how this equipment will be maintained, who is going to run this equipment, how will it be utilized. So we have equipment that is bought that will be useful, but is in boxes. So today we have a CT scan sitting somewhere, but someone has to travel 400 kilometers to get the same service. And you know what group is going to be very happy with a UHC program that focuses on treating common colds and skin rashes? The entrepreneurs who are equally happy with the MES scheme. We have to change that. Let us have investments that actually make a difference in people's lives.
Okay, we will take a break at this point. When we come back, you'll have a chance to ask just one question, and then we'll get the jury involved in terms of asking you questions on this topic. We'll be right back. Welcome back to the debate. A quick reminder for you to engage with us on this debate. We are debating universal health coverage and the government's priorities and where the investments should go to. We start off this section with cross-examination, the opportunity to debaters to question each other. We start with you, Dr. Ngani. You can go ahead with your question to Dr. Rono.
Thank you, Joe. Dr. Rono, you have correctly said that NHIF is for the privileged few. It sounds ridiculous because it's 500 a month, but that's the reality. About 80% of Kenya's population cannot afford to pay 500 shillings a month to NHIF, and if they can't afford that, then they can definitely not afford the private insurance or employer-provided private insurance. This is the reality. So my question is, if 80% cannot afford 6,000 a year for healthcare, what happens to them when they have cancer? And cancer requires 333,000 a year to treat. We have more than 80,000 people in this country today, the prevalence, 47,000 patients getting cancer every year. What happens to those people who require dialysis, currently costed at about 19,000 every week, meaning it's almost 80,000 every month. What happens to those people who need some form of surgery? How do you propose that this 80% of Kenya's population, 80% of those who need these services, who cannot afford to pay 6,000 a month, how do you propose that they afford these services?
Thank you. I think your question really brings home the point that we need to invest in primary healthcare. So the question here is, why are these 80% struggling to pay the 500 shillings? It comes down to health-seeking behavior and our response to needs, financial needs as a people. And it comes down to one thing, trust. Does that person who is in the 80% trust the system for him to put his 500 shillings voluntarily? No, they don't, because they went to the dispensary next to their home, they didn't find medicine. They went to the dispensary, they couldn't get a diagnosis for malaria. So we need to fix that trust element before we can ask people to bring in money. So how do we fix the trust element? It's the simple things. Make sure the primary health care is working, the doctors are well remunerated, they're present at work, the community health worker is visiting homes, making sure people are immunized. Then you can ask the household to pay the 500 to cater for a higher level of care. So we need to address the trust component, because ultimately health is about people. It's about their trust in the system. And to your question about how do we fund this, I think there's significant evidence that the best way to fund UHC is through a non-voluntary mechanism that is efficient. What is the most efficient way to collect money in Kenya for the populace? It's largely around taxes, and government is already doing that. The question is, how do you expand that bracket to tax everybody, so not just people in the formal sector? That's a lot more efficient than saying, let's collect 500 shillings from people, because the cost of collecting that 500 it's probably 200 or 300 shillings because you have to make follow-ups. Households don't follow through it every month. So do you follow up and make sure they pay? So the efficiency is quite low. So you collect 500, but really you're collecting 200 shillings. So we need to go back and say, if UHC is to be funded through a non-voluntary mechanism that gives people a benefit to which they don't need to pay out of pocket when they seek healthcare, then that means we go back to government and say, okay, let's look at the taxes we are collecting, the revenue we are collecting, and then deploy it in the most appropriate way. If we do that, what's the net effect? The net effect is that we have a stronger primary healthcare system that is geared towards more promotive, preventive healthcare. So fewer and fewer people get to levels that are severely advanced that they need tertiary healthcare. So it's a question of how do you prevent the cancer, how do you prevent the stroke before it happens? Because our fiscal space, the money we have...
I'm sorry, I know the time will run out before you actually answer my question, because what you're answering is completely different. Number one, the issue around this treatment is not a question of trust, it's a question of desperation. Many of these families are actually desperate, and at that point they'll access any care that they want. Number two, if you've said that we are not, can I say, rich enough, or we are not privileged enough to be able to afford NHIF, then in the same sentence, you're talking about non-voluntary. It means that not only it's not because you cannot afford it, now we'll make the government force you to pay it. That's not the issue. We need to answer this question where the primary healthcare system has worked. We've actually diagnosed through whatever means that they have cancer, they have kidney failure, we've acknowledged it. Now it's time to pay for it. If our UHC focuses primarily on primary care and ignores this other care, what do we tell these families? And make no mistake, this is literally a matter of life and death for these families.
And so my point exactly, I'm not saying that it's a question of desperation versus trust. Let's not focus on treating the symptom. What is the root cause? Why is this patient here with stroke?
Dr. Ron, this is not a symptom, this is a disease. Somebody is literally...
Yeah, so the patient is here with stroke, but where did that problem start? It started with hypertension 3 years ago at a primary healthcare center. That person didn't seek healthcare, maybe because they don't have cover. Why don't they have cover? They don't trust the system. So you kind of have to address the person and the community and say, okay, we want you to prepay for healthcare, to augment whatever healthcare is being funded by government. But the person doesn't trust the system. So how do you build that trust? You build that trust by the first point of entry to the health system. Where does this person enter the health system? It's the primary healthcare. So even if we have a very good tertiary, but their first entry point was disappointing, the patient didn't even have a chance to get to that tertiary. They went into this first dispensary, didn't get the services they liked. They were like, okay, this system doesn't work. I will not put in my money. I'll go elsewhere. But
okay.
if we invest properly in primary healthcare, then you get a chance to build the trust in the citizens to contribute towards health, to demand from their governments that investments are made towards health, so that when we have politicians and the political elite talking about campaign pledges, we don't say, okay, we'll build a road and a bridge because we can see it. They are building a road and a bridge because the populace are asking for it. But we haven't built the trust in our communities to the point where they can say, no, I don't want the bridge. I want this dispensary to work. I want that health facility to work. I want the softer social services and not the hard infrastructural services. So I think ultimately it's about the people. And how do you get people to rally around this idea that health is your right? Yes, resources are limited. So it's a question of where do you put it. I'm not saying we have to put it only in primary healthcare. It's a question of, okay, if we collect 1 million shillings, where do we put the bulk of it?
Okay, so Dr. Rono, I'll now give you a chance to ask your question to Dr. Ngani.
Yeah, thanks. So my question is really around what, as a people, as Kenyans, when we say we are going for universal health coverage, what is universal? Is universal you and me, the privileged who are here, who can afford voluntary contributions to NHIF, or we are civil servants and we get paid for by NHIF? Mm-hmm. Or is the universal about the many other people out there who don't have that privilege? And I come back to my point that NHIF is not government investment. It's a membership. Those of us who are members of NHIF are putting in money and we can get care. The question is, what do you do with everybody else who is outside this privileged group? And that, for me, is the universal aspect. And ultimately, my question again is, if health, to a big part, health is a social good, and we saw that with COVID, we see that with immunization. The fact that I'm immunized is not good enough. I need everybody immunized to make sure everyone is protected. How do we get to that universal if we focus our investment on a few select group that are more privileged than the rest of the population, keeping in mind the privilege here, probably 20% or less.
Okay. Dr. Ngani?
I think my colleague, Dr. Rono, has watched a lot of American debates where when a question is asked, you circumvent it and give a different answer, and you don't answer the precise point. So I'll do something different. I'll answer the question directly to both of them. The first question is, who do we mean when we talk about universal? When we talk about universal, we mean everybody, every single Kenyan, including the child who was born today. The richest person in the country and the poorest person in the country, the person who's struggling to put a meal on the table, that is the person you're addressing. And with that understanding, then the next questions become clear. Number two, what do we do with these individuals who are not currently in NHIF? And I'll go back to what Dr. Rono said. He said that the reason there's disappointment, people are not contributing because there's disappointment in the system when they are accessed. And this is true. There are two reasons why people don't contribute. For a group of people, it's because NHIF just didn't make sense. You're making payments, and when you need healthcare, you still have to go back into your pocket to access healthcare. That's number one. I'll come back to that. That's a big part of this conversation. The second group simply cannot afford it. And one of the positives from the evolution is that some county governments that are proactive actually looked at the indigent populations in their counties and were actually making the payments for those families every year. The investment was actually quite reasonable. It's a direct intervention that allows us to achieve UHC. In a number of statements, Dr. Rono has played the role of NHIF in UHC. I want to say categorically that for Kenya, the fastest, most efficient route to UHC is through NHIF. How we fund NHIF is a different conversation. There are single payer systems. This is not that conversation. The question is, how do we cover everybody to meet all their healthcare needs without them going into distress? That is UHC as I define it. You can define it differently, but I want to believe that is the definition that exists today. The issue about whether this tertiary and secondary is for select few is a complete misunderstanding of what tertiary and secondary is. So it is not for the privileged few who have NHIF, it's for everybody. When he said that we are investing in CT scans to ensure that it can be done, you don't have to travel to Nairobi. We want to send you a surgeon, not to come to Nairobi for some surgery, but to have it in your, within your locality. That is actually a fundamental right that is being extended. As it is today, our healthcare system is highly skewed. Only the rich, only those who have NHIF can access dialysis, can access surgery, can access admissions, can see consultants. That is the reality today. To change that, we have to make these other services accessible to the population that cannot afford to pay. And there are two ways to go about it, either to fund them into a point of accessing NHIF or to actually put money through government into these systems that allow them to access these services. I want to tell you it's possible, but we have to be deliberate about it.
Yeah, but I think we missed the point here about NHIF and how we fund it. You mentioned that the surge in numbers in voluntary cases when there was surgery and dialysis. That just doesn't mean that investments in tertiary healthcare are paying off. It just talks about...
No, Dr. Ron. It means that the benefits package that touches on the real material issues is paying off. When people go to NHIF and find, I can get surgery, I can get dialysis, I can get cancer care, it actually is responsive. And as a result, they don't ask me, ask the people. They'll tell you this is the reason why between 2013 and 2017, the numbers went up. In 2017, NHIF paid 100% of the cost for everybody who required cardiac surgery. This is tertiary care. Now, from around 2020, when NHIF benefits started going down, look at what has happened to their numbers. Its benefits not in primary. Primary has remained constant. In fact, right now, any NHIF hospital you go to, you'll get primary care. But tertiary care and secondary care has gone down, and as a result, subscriptions are going down.
And I think
it's as indicative as possible.
The point I'm trying to make is the changes in the numbers of people enrolling into NHIF, that is not a reflection of investments in tertiary healthcare. It's a reflection of the people and the trust I talked about. I mentioned that people are not willingly contribute to NHIF.
You cannot distinguish can I say the trust and from the benefits. You see, the trust is because the tertiary services are available. But if they're not available, they don't trust.
Dr. Ngani, so the point you're making is that where the real pain is being felt is in the secondary and tertiary.
Absolutely. And not only that, I'm saying that when those are addressed, you can see the confidence and the support that the public gets, and actually the positive sentiments relating to NHIF when those areas are addressed.
Subscriptions into NHIF.
Yeah, absolutely.
But the point I'm making is that that's not the correct position. The correct position is that we are seeing a surge in numbers in people contributing to NHIF because of what we call a moral hazard or adverse effect, in the sense that I'm not covered by NHIF, but I go see my doctor. He tells me I need dialysis for the rest of my life. I start paying for NHIF, and then now I'm part of the numbers. So the numbers go up. NHIF becomes almost financially insolvent, and that's where the position they were in close to 2017, 2018, and they stopped a lot of the benefits. So to Dr. Ngani's point, by 2020, the numbers in NHIF begin to drop because now NHIF is potentially insolvent, payments are not going to clinicians, patients are losing trust, they're pulling back from the system. So what we need is something much more systemic, something more long-term than this, ad hoc investments in covering surgery that just really creates an artificial spike in numbers. We need to actually invest in something more long-term. And by long-term, if I can put the question to Dr. Ngani more concisely, is Kenya has a limited government. Again, coming back to the topic of the debate, government investment is limited. So if we say government has 100 shillings, and the question here is, should that 100 shillings focus more on primary or tertiary? It's a spectrum. It's a question of where do you put more of that money? Do you put that money in paying for vaccines for children under 5 that covers all the children in the country if your money is limited? Or do you spend the little money to buy a CT scan machine or invest in tertiary healthcare, which will serve maybe 1 or 2% of the population? The question here is, where is the government money going? And it's not limited.
So we'll cross the floor now. I'd like the jurors to help clarify on issues through their questions. We will start with Marie. Indicate the person to whom your question is directed to.
Thank you so much. I think this question is to both debaters. Very interesting insights being shared. And I'll phrase it with the common analogy in healthcare financing, where we say 15% of a chicken is not 15% of an elephant. And in our healthcare system, the topic of today is investments and government investments. We've talked about how we should be at 15%, we're at give or take 4%, but even as we look at it realistically, that 4% is not being used optimally. So I am curious to know, why should we go to 15% if we are not using the 4% optimally? And why should we use it for each of your instances? Thank you.
You're absolutely right. At some point, when I was leading the doctors' union, I thought we need to invest 15%, but actually I realized what we need to do is improve efficiency. We can actually achieve tremendous improvements in healthcare today using the existing resources. We are highly inefficient as a country. We have allowed corruption to worm its way into everything that we do. We have allowed for what we'd call sort of entrepreneurs who are happy to supply, things that don't work in a health system. So there is a significant part for us to play collectively in terms of governance in healthcare to allow for these healthcare services to work the way they're supposed to be. The question of government investment, my take and my point is, let us invest where there is impact. There is no point in putting together, putting our limited resources in a space where entrepreneurs will be more than happy to supply chalk because the impact is limited. But if we can invest the limited resources we have in places where family is actually struggling, then we actually have better outcomes. This is, in a nutshell, the proposal that I'm making.
All right, Dr. Rono.
Thanks for the question. And just to clarify, my earlier statement is not a concession to this debate. It's really putting it in the right framing, that it is a spectrum. That's the reality. It's a question of where do you put more weight with the money you have. So I just wanted to clarify that. But to the question about whether we should go to 15% or 4%, it's a question of looking at the efficiency in the system. And again, I'm not sounding academic, but if you look at a health financing arrangement, you simply have 3 buckets. You collect the revenue, you pull the risk, and then you do the purchasing. Where we go wrong, in my view, is at the purchasing point. A lot of the purchasing is very passive. A lot of the cases of corruption or embezzlement of funds have happened at the purchasing point, where we're saying we are questioning KEMSA purchasing drugs, we are questioning NHIF paying for healthcare services, and we're not really doing strategic purchasing. And what is strategic purchasing? Strategic purchasing means going beyond just looking at the price and paying for the process, and putting healthcare providers to task and say, rather than me paying you for the X-ray, or paying you for this tablet or paying you for this MRI. I want to pay you for health outcomes. And in more developed economies where you have health management organizations, people are paying, saying, okay, I'll pay premiums to you, but give me 90% outcome, successful outcome for breast cancer. So the provider is at task, not just to issue procedures, but to actually ensure the outcome is good. We're not there yet. How do we get there in Kenya? In Kenya, a lot of the payments that are being done are for procedures and items. So you're paying for medicine. Whether you recovered or not is not part of this payment process. How do you get that into the payment process? You need to find a way to get feedback from the patient into the system to say, okay, yes, I went in for an MRI, I got these procedures, and I got paid. How do you get that follow-up? That follow-up happens in the community. So
it becomes outcomes-based?
Yes, and that outcome has to come from communities and households. That goes back to primary healthcare, because yes, you went for surgery at a tertiary healthcare facility. All your follow-ups and whether you did well the year after that are probably happening at the primary healthcare level. So
please note what Dr. Rono said, that the outcome measure here is good outcomes for breast cancer. We can't run away from it. It's the reality of today. That is secondary, actually tertiary care.
No, that's an example I'm giving, and I'm saying
it's the correct example, because I know you're in tune with where the population is.
No. I'm not saying breast cancer to say we need to invest in tertiary healthcare. I'm saying that.
Are you saying we shouldn't invest in breast cancer treatment?
No, I'm saying we should, but my question is, in the spectrum of things, if you are the health minister or the minister of treasury today, you have 100 shillings on the table. Do you say that, okay, I need to make my payments for vaccines through a platform like the Gavi platform, where because of pooled procurement, the cost of the vaccine is now $3, yet in the market is 100. So do you ask yourself, okay, do I pay for that $3? Or do I buy this CT scan that will take 80 shillings out of the 100?
And this is why I said this conversation is between quality and quantity, because the focus as academic looks at quantity and says at these numbers, but in reality, when you talk about impact, if you go back to the community, the things that have been most impactful, which is why we should invest, are the things that are driving families to poverty. And those things are not the fact that I had a headache and had to go and get paracetamol at the health center. No, it's not even the most significant illnesses that exist that don't require admission. It's the illnesses that drive families into hospitals that then have to be
points. I
think the message is home. The carrier has considered multiple times, and I hope that all of us who are listening, kwa mwendo wa aste tutavuka sakafu, tuunge mkono mjadala huu semao kwamba tupinge mjadala huu semao kwamba we only invest in primary healthcare. Let's invest in primary, secondary, and tertiary healthcare.
I'll come back to my point about the spectrum.
10 seconds.
And the point here I'm trying to make is that it's a spectrum of where you put your money. So my colleague talked about cancer. So talk about HPV infections and cervical cancer. Do you, as a health minister, invest in the vaccines upfront and put that through routine immunization? Or do you wait until people have cervical cancer and you need tertiary healthcare?
All right.
The money is limited. You've got to make a decision.
I have a follow-up question now that we're still focusing on the money bit, and you picked part of my bone on leadership and governance. We are talking about investments, which is a money issue, that is true, and we also need to figure out where we're going to put this money. And for any of your systems to work, it needs people to make it run. So I think my key question will be, where should we invest, especially now looking closer to it on human resources for health, because we've had reports in the media saying doctors are not there. We have doctors saying they are on the ground, but they are more or less like soldiers without the proper artillery, not able to do their work. So if you are the government, you have this amount of money, you have to buy medications, you have a huge populace of increasing healthcare workers due to the increasing health science schools in the country, many of them who are not getting job security after their mandatory 1-year internship. And then you have a health system that has a gap that needs to be addressed. And you've mentioned NHS. So I'm curious, in the human resource angle, how do we tackle these investments to ensure that in the end, with the symbiosis, we have people who are able to offer services and we have investments, an X amount of money. So how do we collaborate, especially in community health, where most of them are volunteers?
So 20 seconds each of you to respond.
So the first thing is make it people focused. We can actually sit in hotels and boardrooms as healthcare workers, as office people, and then dictate what works. Or we can take the reverse and ask the people, where do you want them to where do you want us to invest? And they'll tell you, invest in the services that then become responsive. Number two, As far as human resources go, what do we need to do? We need to empower them. How do you empower them? A neurosurgeon requires a theater, requires a CT scan, make those investments available. I'm an ICU doctor. I can come to a space. If I only have certain things that I don't have others, my work will be limited. So let us empower our healthcare personnel, give them the resources that they need, give them the equipment that they need, ensure that the secondary and tertiary part of what they do makes sense. There's no point in having a senior doctor who can do 30 cesarean sections in a month and able to do a single one because the equipment is not there, because we didn't prioritize that.
Dr. Rono?
Yes, 20 seconds. Yeah, for me, the human resource aspect is multiple-fold. There's one part where, at the bottom line, we need to say, okay, back to government investments. There's a basket of money we've collected. Where are we putting that money? Are we putting it in roads, in bridges, in mining? Do those give us a better return than health? The argument is no, health gives you better return. So it's a question of, from this big kitty we call treasury, let's put more of it into health. That's the first bit. And then the second one, once that money is into health, the question is, where do you put it? And where do you give more weight? In my view, we need to focus on, yes, increasing the number of healthcare workers. I think we still don't have enough healthcare workers employed and providing services. And we need to get them into the system. But there's a concept of task shifting where we're saying, let every level of ailment or health condition be managed at the level it needs to be managed. A lot of the cases that can be managed at community health level need to be managed at community health level. Right. They are not, because community health workers are not empowered.
Okay, Dr. Rono, I need to move us along. We now take one question from Dr. Ibrahim.
Thank you so much for the insightful debate. My question goes to Dr. Ngani. You talked a lot about cervical cancer, let's say cancer in general. Now, if you talk about specifically cervical cancer, breast cancer, would you feel like it's better for you to concentrate more on the treatment or the prevention of the cancers?
I say we have to focus on the full spectrum. And in fact, that is in the very definition of UHC. It says the full spectrum from health promotion all the way to treatment. I recognize that prevention is indeed the best treatment for all types of cancers, and in particular HPV and breast cancer, where we can actually have early detection and make some measures to reduce that. However, I also know that there are over 30,000 women in this country today who have breast cancer, and the incidence is significant. These are the two most common leading cancers. For this 30,000 plus, what do we do? And I know that we need to be responsive. Look, the mortality from breast cancer in the United States is less than 10%. In Kenya, it is 50%. How do we break that gap? Yes, they have cancer, but there's clear evidence that if the health system works, if the secondary and tertiary care is well done, then we'll actually save another 40% of the mothers who have breast cancer. And if we can do something, we are mandated morally to do something about it. The NHS in the UK does the exact same thing. It's a universal healthcare system. It's a single payer system where the government is paying through tax, yet every single person there is able to access these high levels of care. Why should we say it's good enough for the UK citizen, but not good enough for the Kenyan citizen? I reject that proposal. I say that if it's good enough for the European child, it's good enough for the Kenyan child.
I think Dr. Ngani has considered that we need to focus on the preventive, because again, let's look at the reality. Let's get back to the debate and on the facts. The money on the table is not limited. Where do you put it? Do you put it on the HPV vaccine, or do you treat advanced level cervical cancer?
So an issue of prioritization, where the money should be prioritized.
It's actually not a concession, Dr. Rono. I'm saying that I've understood what you're saying, but I'm also saying that I'm calling you to, and I've seen further, and I'm calling you now to see the further with me. I'm saying prevention is important, but beyond prevention, there's something else we need to do. So could we now move from that level or to the next level and look at the actual situation on the ground and actually do what is required for us to improve healthcare outcomes for our people?
Our final question from Dr. Serena.
Yes, thank you very much. Both of you have put across very good points. And so Dr. Ibrahim took the question out of my mouth. So my question would be in addition to his, and probably give you a bit more time to put across the points that you want to put across. But so you've mentioned that, and you've agreed, yes, that prevention is better than cure. So my question to you then would be, would you then say that the cases that you're basing your debate on, and the people that have to spend so much money out of pocket, for care in cancer, in cardiovascular diseases that need specialty surgery, that points to the failures that exist within the primary healthcare system. So would you say that that is the case? And then just now expound on that a bit more.
Two things are actually to be considered. Number one, in healthcare in general, you do have to invest significantly in preventing illnesses. That's not in question. We're talking about steps like preventing cancer. What do? You need to stop smoking. You need to reduce alcohol intake, exercise, sedentary lifestyle, and so on. These are things that need to be done. We are also saying that in our country today, the disease burden is significant. My opponent is suggesting that we focus only on primary healthcare. That's where we put our resources heavily. And I'm saying that where we are as a country today, if we look at the main purpose of UHC, and I think this is the fundamental question in this debate, what is UHC trying to achieve? It's trying to achieve a situation where you meet all your healthcare needs without facing financial burdens. You are healthcare workers. You know that many families are struggling to meet the cost of healthcare. Where is that struggle? It's not a question of whether we should prevent illnesses or treat illnesses. It's a question of how do you protect the families from these financial burdens. And you will agree with me, it is not because of stopping smoking the message. No. It is not because of the skin infections that they must treat. No. It is because of the things that take them to hospital. Many families cannot afford 10,000 shillings in a month to pay for certain healthcare conditions. This is where the investment makes an impact. This is where the objective of UHC has to be achieved. I know there are many academic papers that speak about primary healthcare, but I want you to go and observe. Those papers are primarily focused on Africa and countries where they talk about limited resources, because there's a certain quality of healthcare for limited resource people and certain quality of healthcare for people who actually are meant to live in this world. And I'm saying we reject that. Impact, there's evidence in our country today that if we invest in these areas that are ailing the Kenyan citizens, these areas that are making them go into poverty, they actually appreciate it, and healthcare is generally better. NHIF has proven it. Between 2013 and 2017, the investments in that place, you can see the mark of confidence that arose out of this.
I will now bring us to the closing statement. We'll start with you, Dr. Rono. Your closing statement, your opportunity to keep the jurors on your side, and then we'll take 1 minute, Dr. Ngani.
Back to the debate we have here today. Today we are asking ourselves, where do we put government investments? And when we talk about government investments, let's be clear what that is. It's not NHIF. There's no government money in NHIF. Let's talk about government investments. And so, talking about government investments, are we the first people to go into universal health coverage? No, we are not. We don't need to redo all the mistakes other people have done. So who has done it right? The countries that have done really well include Thailand, Indonesia. How have they done it? They've gone into primary healthcare, invested in what protects the majority of the people, in their immunization, in nutrition, in hand washing, in the primary items. Then what that does is that you have fewer and fewer people who then get to an ICU, fewer and fewer people who need to go into a cath lab. And now you can afford care for those fewer people, but you've got to find a way to close the tap. And by closing the tap means go into the community, go into the primary healthcare level and say, how do we make sure these people stay healthy? We are not in the business of treating diseases. We're in the business of keeping people healthy. That's the primary focus of universal health coverage. And how do we do that? Primary healthcare. And I dare say not just primary healthcare, but community-centered primary healthcare. If we get a lot more people staying healthy, we have fewer people getting sick, and we can cover them with available resources. Thank you.
Thank you, Dr. Rono. Dr. Ngani, your 1 minute closing statement.
One of the absolute best examples of government investment in healthcare, in universal healthcare system, is a NHC in the UK. One of the absolute best. That is a gold standard of UHC that is government funded with government investment. And that has to be our standard. I want to urge us to move away from comparing ourselves to countries that may not necessarily be optimal in what they're doing. If we are to avoid the mistakes of others, let us look at the people we should be aspiring to emulate. And currently, the NHS works very well in the UK. And if the NHS works, then that is what we move towards. And in that setup, the focus is across the entire spectrum. It's a focus that has tertiary care taken care of. It has secondary care taken care of. In fact, quaternary care is taken care of. It's a system that many people are aiming to emulate. If that is what works best, then that is what we should be aspiring towards. In Kenya today, our biggest burden, what is driving families into the ground. You have worked your whole life. 2 weeks in ICU makes you sell the property that would have kept you going forward for the next 5 years. So those investments are investments should make for us to be true to the meaning and purpose of UHC. Let us not forget what UHCs are aiming to achieve. Back to the basics. The fundamentals are access to the services you need, and without exposing you to financial burden. If you do primary health care only, the financial burden will remain true for many families, and that will beat the sole purpose of UHC.
Thank you very much. We have to bring it to a close at this point. I'm not sure who has done enough, whether Dr. Rono, you've lost the jurors, or Dr. Ngani, you've won them over. We now give the jury team an opportunity to make their closing verdict. Let us find out where they stand.
At the beginning of the debate, all jurors were in support of the motion. Have the debaters managed to win over the jurors with their argument?
Well, the jurors' verdict is in. At the end of this debate on the motion, let it be resolved, the government's investment in universal health coverage should focus on primary health care, not secondary and tertiary care. 2 out of 3 of the jury members are in support. 1 has shifted to the opposition. So I think, Dr. Ngani, you've done quite a bit to win over 1 of the jury members. That is the position of the jury team. Do you back at home agree with it? This was an important conversation. It's a conversation that continues. We welcome your feedback and comments on this debate. Please engage with us on our social media handles appearing on your screen right now. Well, that's it for this edition of We Debate. A big thank you to our 2 debaters for the insightful and in-depth arguments and positions that you've shared. A big thank you to our location hosts, the Norfolk Hotel, the KTN team behind this production, the members of the jury team, as well as you, the viewer, for tuning in and participating in this particular show. I'm Joe Munene, and I'll see you at the next debate.